Hi everyone, welcome to the webinar today. This webinar is called Ultrasound Evaluation of the Posterior Knee. My name is Laura Jaga and I will be moderating today's webinar. Before we begin, please be advised, all attendees are muted. You may type your questions in the Q&A box at the bottom of your screen at any time, and we will conduct a Q&A session at the end of the presentation and demonstration. This webinar will be recorded and archived for future reference on our webinar's website. Here with us today, we have Daniel Shelton. Daniel Shelton is the Director of Musculoskeletal Market Development for FUJIFILM Sonosite. Daniel spent 18 years as a dedicated musculoskeletal sonographer, and 12 of those years have been here at Sonosite. He now leads musculoskeletal market development, where he works to spread the word about the benefits of point-of-care ultrasound. And with that, I will turn it over to you, Daniel.
All right, thanks, Laura, and thanks everybody for joining us. This is part 3, so if you haven't attended the anterior knee, which included the suprapatellar structures and infrapatellar structures, and then part 2 was medial and lateral structures like our collateral ligaments, iliotibial band, etc. And now we're going to wrap it up on the basic knee evaluation on the posterior knee, where we talk about Baker's cyst, anatomy, neurovascular structures, and then we'll wrap up some of that anatomy that we left off on the lateral knee, where it kind of tapers in with the posterior structures like biceps femoris and the common peroneal nerve. So we'll go ahead and get started on the Baker's cyst anatomy first. And this is also referred to as a semimembranosus gastrocnemius bursa, or the Baker's cyst. My favorite landmark to have everybody start with is the medial femoral condyle. So again, if you've attended the rest of these webinars, you're familiar with the teaching style here. We scan for the bones first, and that is this medial femoral condyle. Capping it is a hypoechoic or anechoic articular hyaline cartilage, which is this dark area here. And then there's a tendon sitting right on the top of this, and this is the semimembranosus tendon number 3. And then we have over here the medial head of the gastrocnemius tendon, so that's number 4. And then way over here off screen is the muscle of medial head of the gastroc. So we're taking that slice about where this diagram says we are. And you can notice that the tendons proximally are diving down deep, mostly to insert on the posterior tibia, the semimembranosus, for example. Superficial to that is this one little dot right there, and that's the semitendinosus, which we don't talk about in the slide so much, but we'll image it when we're trying to identify all the little circles on the screen. And then coming in from distal to proximal is the medial head of the gastroc, and they scissor right here, and I'll show you that in the live scan, what I mean by the scissoring. And that's where this Baker's cyst comes out, protrudes from the joint, gets trapped between these two structures, and it acts like a valve, and it can't, it's like fluid, excess fluid in the knee joint can leave the knee, but it gets trapped and it can't go back in. So if you are already doing ultrasound and maybe you've seen Baker's cyst back here, there's also artifact associated with the angle of the ultrasound beam, especially in the shoulder. We showed the biceps tendon, for example, for the anisotropic artifact. This is a really big deal back here. So if you're not holding the transducer correctly, you're going to have a dark semimembranosus and a bright medial head gastroc, or the other way around. If you're tilting the probe, say, towards the feet, you may end up with a bright semimembranosus and a dark medial head of the gastroc. And what you don't want to do is go chasing one of those dark structures with a needle to find out that it's solid and it's a tendon and it's not going to be able to be aspirated. So we'll troubleshoot that stuff in the live scan here just shortly, but let's colorize that anatomy here for your reference. You can go back in the recording and screen grab these for your own notes, but we are going to towards the end of the slides talk a little bit more about this tibial nerve in the back of the knee and some of the other structures around it to look for. But here it is colorized, basically the same thing I just said. And here's what a Baker's cyst looks like. So this big comma shaped structure, it's usually hypo or anechoic. And ultrasound does a great job at telling whether or not it can be aspirated. So if it's cystic and has a lot of free fluid in it, basically underneath this big dark cystic area, the tissue will be extremely bright. And that's because the fluid is relatively enhancing the tissues underneath it, like scanning through a bladder. So if you're scanning through a bladder in the pelvis, you'll notice that the fluid collection of the bladder basically amplifies the sound waves that are underneath the bladder. And that's the same thing that's happening here. So if we have a big, bright, hyperechoic undersurface or deep surface to the Baker's cyst, it's compressible, you could chase that with the needle and aspirate that, no problem. But if it does not posteriorly enhance, and that's what we call this, even though it's they should just call it somehow that it's enhancing deep, because this would be the anterior part of the knee, for example. I don't like that we call it posterior acoustic enhancement, but it is acoustic enhancement deep to the hypoechoic cystic structure here. So if it is acoustically enhanced, you can usually aspirate it just fine. If it's not acoustically enhanced, it may have solidified into that frustrating gelatinous material that sometimes you get out of ganglion cysts. Other structures to avoid that are dark and can appear like fluid structures are these neurovascular structures down here. So let's avoid big red. You can see how close the cyst comes to the tibial artery, and then the nerve is just sitting superficial to these guys. So ultrasound does a great job at where to place the needle, and you can just come in typically from medial to lateral, or some people just drop the needle out of plane right there and just pop into the cyst and aspirate. It's just if you can't get all of this collection, the long axis is usually a better approach to go chase those loculations. Here's the color anatomy for your future reference. Screen grab that if you're studying these notes later. Here it is in long axis. So we're going to see the animation turn the transducer to long axis. And here's that scissoring effect I was talking about on the anatomy. So proximally to distally, we've got the semimembranosus diving to the posterior tibia. And then distally, we've got the medial head of the gastrocnemius muscle tapering to this kind of funnel feather-shaped tendon that borders the medial head, the semimembranosus right there, and it dives in the opposite direction. So that's when I say in short axis, you're going to get one to be bright and the other will be dark, vice versa. Here's what the cyst will look like, top and bottom of that medial head of the gastroc. And I know that's the medial head of the gastroc because it starts bigger and gets smaller and dives deeper as it goes proximally. So I'm not over the semimembranosus, for example. That would start superficially proximally and dive deep distally. Incidentally, a cool piece of anatomy we're not going to talk about today because that's more of an advanced topic to go chase the PCL from its origin to its insertion, but the distal insertion is very easy to see, so we will scan that in the live scan just for fun. All right, so incidentally over here laterally, what do we call a structure that does not protrude from the medial head of the gastrocnemius and the semimembranosus bursa? If it's lateral in nature, it's considered a ganglion cyst or a posterior. It could be a posterior lateral meniscal cyst. So it's not classified necessarily as a true Baker cyst because a true Baker cyst does need to protrude between these two structures. If it's lateral or anywhere else out here, you can just classify it as a posterior cyst, ganglion cyst typically, or if you do chase the little comma-shaped cystic structure down to the meniscus, then you could make that call. Now, if you expect some sort of meniscal pathology back here and you don't see it, don't rule it out. But if you do see a big old meniscal cyst back here, then you're probably right. Ultrasound confirms these meniscal cysts all the time. And once your eye-hand coordination gets under control, you can chase those right down to the area where the tear might be. But in your early phase, this may be a tricky diagnosis. So don't rely on ultrasound to diagnose and rule out meniscal pathology. But I will say, like I've said before, especially in the shoulder, if you see it and you can confirm it with ultrasound, then you're right. You're probably right. But if you clinically suspect some sort of meniscal pathology, you put the ultrasound down and you don't find anything, you can't quite rule it out. Still go with your clinical gut on that and order the appropriate exam like an MRI. So now we will switch to the live demo. So today we're going to be scanning with the Sonosite PX. I'll be using the L15 to 4 transducer. Because we're going to be scanning both medially in some cases and laterally, once we get over to the peroneal nerve anatomy, for example, in the biceps femoris, I may start off scanning this part of the knee for the camera and then just switch over to this part. So if at any time somebody can't see something super clearly, just let me know. But basically we're going to be scanning cross-sectionally. When I first started trying to scan Baker cysts, I kept the probe smack in the middle of the in the middle of the knee, and I wasn't taught initially to go chase down the bony landmarks like I should. So I will say look for that medial femoral condyle first, and then scan proximally and distally to identify that semimembranosus tendon next. So we'll do that real quick. Chamber 2. going to bump the camera down just a touch so you can see the ultrasound transducer. All right. I think I'll start left side of the screen will be medial, patient's right knee. So I'm just going to start here. I used to start in the middle of the knee and just start scanning and looking for a Baker cyst. But once it was really clarified to me back in the day, hey, you know, these really exist every time right here over the medial femoral condyle. I never felt like I was going to miss a Baker cyst again. So let's go over that. Let me bring the arrow up. Here we go. So first things first, is this the medial femoral condyle or is this the tibia? And we can investigate that by what we're seeing on top of the bone. So we have the cortex of a bone. I don't know if it's the femur or the tibia yet. I'm going to go distally until the bone disappears. Okay. And then I'm going to go proximally until I get maybe even another bone. Okay. So I scanned over another bone. So let's find out which one that is. As I went proximally, I know that it's probably the femur, but let's just double check our work. So here's the cortex of what I think is the medial femoral condyle. Now, the medial femoral condyle has that big articular hyaline cartilage cap, and our patient's young, so plenty of tread on the tire here. So plenty of cartilage, nice and parallel right over the condyle. And then I'm gonna go chase that other bone down. So I'm gonna go distally, distally, distally. I see the bone disappear. So now I feel like I'm probably in the joint line. So probably seeing some posterior meniscus, anisotropic artifact here, posterior medial meniscus here. And I'm going to go a little bit further distal until I see another bone. Okay, so here's another bone with no articular hyaline cartilage on top. And I see this big dark thing on top. Okay, so let's find out what that is. I mentioned there's a tendon, semimembranosus attaches to the posterior tibia. And those clues that kind of give this away are the tilt of my transducer. So it's leaning back just a little bit, right? And then if I tilt the transducer the other way, will it brighten up or darken? So it didn't brighten up, or it got even darker for me. So that tells me that that tendon right here is diving further away from my probe. So I'm going to tilt my handle more towards the feet and you'll see that brighten up. So that does confirm that was a tendon and not a Baker cyst right here. And notice how the medial head of the gastroc, that tendon is starting to get really dark. Like I said, they're kind of shaped like a scissor, right? So you're going to get one to look good and the other is going to look bad. Very rarely will you get them both to look really good. So now let's go chase that semimembranosus tendon proximally, right where my arrow is. Here we are over the medial femoral condyle. And now here is the not Baker cyst. Okay, so I'm going to move my probe and tilt it. And I'm going to make that tendon turn dark. And I can't tell you how many times I've seen a needle stuck in that thing right there, this black area, or even this one up here. And the needle would get buried in there and they would pull back and get nothing and just assume that this Baker cyst had solidified. And really what it was, and depending on the patient's body habit too, you're really not able to palpate with the transducer as much as I am today. That ability to let the probe angle get away from you relative to the tendon really increases as the patient's size increases. So as your probe is further away from the hamstring, where I can physically sonopalpate the fact that I'm sitting here teeter-tottering the transducer right on the semitendinosus right here. See this oval right up top? It's stacked right up on top of the semimembranosus. I can feel that under my probe, but not on all of the patients that you're going to scan. So as the patients get a little bit thicker, I will say it gets a little bit harder to manage with natural eye-hand coordination, the fact that you could be scanning this structure, which looks a lot like a Baker cyst, and you won't feel that your transducer angle got away from you. So I just kind of caution everybody as you're scanning back here, don't call any dark structure you see a Baker cyst. Go do your investigation, tilt the transducer handle towards the feet and see if that thing brightens up. And you'll notice the right here, lateral to that is the medial head of the gastrocnemius tendon. And then here's the muscle. So this is all the muscle. And watch them, one get bright and the other get dark and vice versa. So that's the relationship between those two. Very easy to scan once that artifact is really pointed out to you. And then the other dark structure up top here, not discussed too much in the PowerPoint, semitendinosus, also easy to track down as it wraps around to the pes. We could confirm that because we just scanned the pes anserine in the last webinar, and I'm just going to trace that distally, further medial. I could elongate it, and I'll probably end up with a very similar view that we got in that medial part of webinar number 2. Okay, so let's confirm a few things in long axis. So here's our tibia, and notice how I can see the entire posterior tibial kind of plateau surface. It's not on the top where the meniscus is necessarily, but I can't do that in the femur. So I'm going to go up and scan the femur, and I can see both femoral condyles, and then I can see that tunnel view starting. So I'm going to go down in depth. I kick the depth down a bit, and then I can see the bottom of that tunnel pretty much. So that does also just sonographically as a landmark. I can see that this is definitely the femur level, and then here's the tibial level. Like I said, not all your patients are going to be this size, so or image this clearly, depending on the machine you have. So you really must scan your sonographic cortical landmarks before you're confident on what's going on in the back of the knee. So clearly identify the posterior tibia, clearly identify the margins of the femur in each condyle, okay? And then you can see that tunnel between the two, and I can see all the way down into that area where our ACL and PCL anatomy starts to get fun. So now I'm just gonna take my transducer back over to the medial femoral condyle, bring my depth up 2 more clicks, and then what I'm gonna do is just rotate the transducer. Left side of the screen will go proximal. I'm gonna keep my Bony reference on the screen. Here we go. So I kept the femoral condyle on the screen. It's the most recognizable. So femoral condyle, here's that articular hyaline cartilage cap. Okay, we can see very clearly the margins of the cartilage. I can chase that cartilage down. We can see the border. This is a very clean look at the posterior medial meniscus here. In fact, I'm just going to drop my frequency a little bit to gen mode. There we go. And you'll see that acts much like a flashlight on the Sonosite PX. So here's that posterior medial meniscus. Just for your reference, it's not the topic of today's discussion necessarily. So we're going to keep chasing the bony landmarks until we're very familiar with where we are. Here's the posterior tibia. Now let's go look for the tendon that sat on top of the medial femoral condyle. So medial femoral condyle, articular hyaline cartilage. Now I'm going to pan the probe from medial to lateral. As I pan from medial, I went too far and I lost the condyle. Now I'm going to go lateral. There I start to see this big comet tail looking tendon. And I want to figure out which tendon that is just to be sure. And I'm going to chase this tendon distally until I see it potentially insert to the posterior tibia. So here it is at its enthesis, so I can confirm that that's semimembranosus. And you will see hamstring tears and avulsions down here. Tendinosis is very prevalent in this area. Just like a rotator cuff, a supraspinatus, look at the tendon diving. This is totally normal, and you just have to dig the transducer in distally, do that heel-toe maneuver to avoid calling that tendinosis or some sort of tear or lesion there. But here's our semimembranosus diving into the posterior tibia. Now, superficial to that, kind of like the ankle, if you've ever scanned a long axis the perineal tendons where the brevis and longus sit on top of each other here. This looks a lot like that same view, just bigger. So here, superficial to that is our semitendinosus long axis, and I can confirm that by just chasing it up proximally, very thin tendon set superficially, and I can feel it and sonopalpate it with my fingers right down the side of the transducer. So just kind of clarifying all these landmarks. I do often see articular hyaline cartilage, follow that all the way down to the posterior neck of the proximal femoral condyle here, and chase that anatomy down for ganglion cysts. I see them trapped back here all the time. And when people bend their knee into a lot of flexion, sometimes they feel a fullness back there, and you get back here and there's no Baker cyst in the classic spot that you would normally expect one. And then just sitting back here like a gutter, I'll often see these solid ganglion cysts just peppered throughout here, often multiloculated. And if they're sitting here, not affected by gravity, then they're typically pretty solid. So look for that posterior acoustic enhancement just as a scanning tip. If Baker cyst stuff is already kind of boring to you, go chase it more proximally up to the medial femoral condyle and see what you find. As I go more lateral to the semimembranosus, okay, so I'm going to keep bringing the transducer lateral. I see the medial head of the gastrocnemius, and that's the muscle there. So this is all muscle, and the tendon was that really thin edge. As I start to approach more medial right there. It's diving and it's going to wrap itself around to the inside border of that proximal medial femoral condyle out of view. Actually in view. Go Sonosite PX. I can chase that right here to its origin. So here's the origin of the medial head of the gastroc. I had not scanned ahead of time and didn't know I was going to see that so clearly, but kind of like scanning a distal biceps tendon in the elbow, I'm just doing a little bit of heel toe rocking and getting that tendon origin here, medial head gastroc, to look really nice and pretty. So we'll just scan that back up to its muscle. If you see Baker cysts in this area and they're ruptured, they'll typically track down the medial head of the gastroc and sit between the medial and lateral heads, or just superficial to that medial head is pretty common. So back to the semimembranosus and thesis, see that landmark, and reason is I don't want to call that the PCL on accident. So if I'm going and chasing down the PCL, what I want to do is just follow this tibial cortex, and I'm going to scan more lateral now. So I'm just going to bring the probe laterally. I see the medial head of the gastroc muscle. Notice how water-filled the muscle is. It's going to acoustically enhance what's underneath it, so everything gets nice and bright and makes it easier to see structures like this. So here's that distal PCL, just for fun. We're not going to go through any diagnostic scanning techniques or dynamic maneuvers for that today. But this is incidentally the PCL. Sometimes it will look like a shadow, and you just don't want to call that a cyst on the meniscus. Those fibers, if you get them in the right angle, look really nice, like a rotator cuff might, or any other inserting tendon. So we'll look at the neurovascular structures here just quickly, but they are on some of the next slides. But incidentally, here's our tibial artery. We can see the walls of the artery very clearly. If I let up my pressure, you'll see the vein. And then superficial to that is our tibial nerve, distal sciatic to tibia. We go cross section just to show that. Left side of the screen will be medial. Look how lateral these structures are. So we get this question all the time about aspirating Baker cysts and just what they're nervous about going in and aspirating, and how far away are these vessels, you know? And I would say they're very far away. If you're chasing something down with ultrasound, we're talking about staying here medial, and we're very medial from midline. If we go more lateral, way over here is where you get into big red and compressible tibial vein. And then here's the nerve, which is not so acoustically enhanced, doesn't really look pretty. You can throw the medial head of the gastroc over the nerve and make it look a little prettier like that. See what I'm doing by angling? I'm just actually using my finger and shoving the gastroc over the nerve, and that acoustically enhances the nerve, makes it kind of look like the median nerve in the forearm. So if you're having a hard time finding the nerve margins, you can come over here medial and throw the gastroc muscle over the nerve and make it look better. Watch the change of the nerve. See how I can see all the fascicles real pretty? But if I just scan down its groove between the medial and lateral head of the gastroc, here there's nothing to really show its margins, and the fascial walls of the gastroc muscle bellies are casting shadows into the nerve. So if you have a hard time seeing the nerve, it's because the walls of the gastroc are casting these shadows down the nerve, making everything look dirty. So you just have to look at something from a different angle sometimes. So if I go up here proximally, the subcutaneous fat will enhance the nerve just a little bit. It's better than the walls of the muscle, but nothing makes a nerve look better than enhancing what it looks like through a muscle. So here you can see it still looks dirty, but through the same level, what I'm going to do is just bring my transducer over medial, and I'm going to throw the wall of the muscle into the nerve, rock, 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 and then aim. And then we get a much prettier nerve right here. So if you are looking at things like we're about to on our slides, I'm going to switch back, go to live demo, and start talking about the neurovascular structures back here. Okay, so here we are scanning. I'm just going to go kind of hurry up offense here. We're on this nerve, and what I did was I threw this muscle over this nerve to make it more amplified. We're going to scan this nerve more proximally now. And we're going to follow it up until we see the biceps femoris tendon. And we're going to scan the biceps femoris tendon just for our confidence level out here to the fibula. But then we're going to see a structure just posterior to that, and that's the common perineal nerve. So we're going to be able to distinguish the perineal nerve branching off the tibial. And then we're going to scan it distally and follow that tibial nerve. And we're going to talk about some other structures that may arise and look like a Baker cyst. And that can be some neural neurovascular malformations and such. So I just showed you this basically between those two heads of the gastrocs. Here's the diagram for your reference in the future. I kind of already verbally went through this while I was scanning, but here's normal as I was scanning just a minute ago. You can see the gastroc over here where the nerve starts to look prettier. Always use your color and find these vessels. But this is a case that I wanted to show you where it came in. This was for a Baker cyst aspiration. It was referred to the radiology department I used to work at. And basically the history here was a patient, construction worker, hangs his hammer off the back of his belt. Every time he would bend over and the hammer would just barely tap the back of his knee, he'd go down in pain, and palpable lump on the back of the knee, painful. So I think it was a PA, nurse practitioner, referred over to see how big the Baker cyst was and if it was easy to aspirate. They had a lot of success with us gauging soft tissue masses in the department and whether or not they were going to be solid or cystic and whether they should chase it down with a needle or not. So this one came in just like many other had. So here's the nerve, it's normal. Here's the nerve at the same level. We had this big schwannoma right in the middle of the nerve. Solid for the most part. It does posterior acoustically enhance a little bit, but this is definitely not a Baker cyst. It would look like a Baker cyst if you were just to plop the probe in the middle of the knee like I said not to do. So if you don't start medially and you just plop the probe right in the middle of the knee, which is where this would live, you would maybe just go ahead and call that a Baker cyst and start measuring things and getting your aspiration supplies ready. But what you have to do is confirm things in two planes. That's how we confirm anything in ultrasound. We have to image things in both planes. We go long axis nerve, same level. You can see that this has beginning, this little egg shape of the schwannoma, and then it dilates out to this huge solid complex mass that starts to die posterior to the tibia and then returns back to its normal diameter if you were to keep scanning. Incidentally, this is a way to stitch the image together and get a 10 centimeter shot, which is plenty big for almost anything we scan back here. So I'll do that dual screen imaging technique on the back of our model's knee here today, just to kind of show you that you can do that too, no matter what machine you have. But just, you know, user beware, not everything back there is a Baker cyst, not everything back there is a fluid collection from the knee joint that can be aspirated. And you should always chase these things down in long and short axis before you go drill into anything with a needle. So back to our live demo. Make sure you can see everything okay. I really haven't left the area. Kind of readjust things. All right, so back to our anatomy. We went through that tibial nerve. Here it was. Model definitely doesn't have one. Easy anatomy to scan. I'm going to go long axis on this nerve. It's right under that medial head gastroc. So I'm just going to spin the transducer. Long axis there. And that's the same level of that last slide. So here we can see the normal nerve. It's nice and parallel. Nerve fascicles don't intertwine like a tendon. They stay nice and parallel all the way through their course. And we can keep tracing that nerve down as it starts to hug the tibia. All right, so I promised you a way to image that in a longer way that's fairly quick. So what I'm going to do is just go out, hit my dual screen here, and hit my right side and scan that distally, get your landmarks to line up right about there. Save that shot. If you did have a soft tissue mass in there, we could save it, start to measure it, whatever. But that's a good 10 centimeter shot that doesn't take a lot of time. It's real easy to do. And every ultrasound machine has a dual screen feature. If you are chasing down a soft tissue mass back here with a needle, you do want to throw your color on. So I just hit the C button on the ultrasound machine, bring my depth up a little bit. And then the Sonosite PX is really nice if you're doing procedures around a lot of neurovascular structures. And the LX series also has this. I want to hit the top bottom button on color, and we can run color compare, and you could be driving a needle down here right up next to whatever soft tissue mass you might be doing, and note that you're staying far away from big red here. The downside to putting color on a screen is that any motion at all sets off all this color artifact. So if you are running a needle in the area, whether the patient moves or you move, you can lose sight of your needle and your anatomy fairly quick with color on. So that's why it's nice to have color on and off simultaneously at the same time while you're doing procedures that are in kind of sensitive neurovascular locations. I'm gonna hit 2D, that gets me out of all of that. Now I promised we would also scan the tibial nerve proximally. Let's add some gel. Check our camera angle, make sure we can see where I'm going. Not quite. Other way. Okay. So a little bit further up the leg here. We're going to find that tibial nerve. Let's chase it down. We can see the fascicles, the internal architecture of that nerve. Okay, so this is where we were. Here's the level of the lateral femoral condyle. Okay. I expect to see the perineal nerve over here kicking out laterally, and I've seen it a lot, so I've already seen it here. But if you don't see it, keep following this nerve proximally from the lateral femoral condyle level. And out here in the subcutaneous fat, right here, this is all sub fat. All right, there's no muscle or anything here just yet. This is the biceps femoris muscle. This is our landmark, just like I showed you in that anatomy diagram. You can already see the perineal nerve coming to join up with the distal sciatic. So here's the sciatic nerve as one here. Here's the biceps femoris again, just lateral to it. So biceps femoris. Here's that bifurcation. Here, you can see those two split off from each other really nicely, very easy to see. And anytime you're scanning nerves, I tell people, take little 1-inch bites of the nerve. Don't just hold the image still, because a lot of times that'll make you get lost if the anatomy all looks the same. If you're in a morbidly obese patient or something, all the tissue can kind of be grainy because they don't have a lot of hypoechoic muscular architecture to enhance what's under it. So it can be frustrating to scan these nerves. So you just take little 1-inch bites, up, down, up, down. We're going to pan proximal, distal, and just chase this this proximal tibial nerve up to the distal sciatic here, and just back, forth, back, forth. Right here, I can see that bifurcation take place. And let's chase the perineal nerve, or the common fibular nerve, depending on when you went to medical school. Here's the fibular nerve in question, or common perineal nerve, and we're going to chase that up. Since it's going superficially, I'm going to bring my depth up more shallow and let the PX send all of its focus and all the other parameters that we're changing for you in the background to a more shallow target. And let's follow this perineal nerve as it borders biceps femoris. Keep following it, keep following it. If it's just the nerve that we're following. Okay, so we went from posterior femoral condyle, right? We're about to jump over the joint. So here's the joint line, just to put things into context where we are on the screen. And noticing that I'm glad I have two cameras here, otherwise some of you guys would be lost. There we go. Just get an audible here. Don't want anybody to be lost. Okay, so I'm at the bony level of the lateral femoral condyle. Now I'm going to go distally, and now I'm over the joint line. And now the next bone is tibia. Okay, and if you've been following that nerve, it's this more flat shadow right here. Here's the biceps femoris right here. So nerve, tibia, and now we're about to see that posterior fibular head be this very superficial bone that's about to come up in the shot right there. And in our model's case, that nerve is already sitting, perched. You just saw that little subluxation there that happens. Crossing your knees when you sit, that's a terrible way to sit, and it can make that nerve sit in an unnatural place, kind of like we just saw the subluxation. I'm going to force that back over fibular head, and we're just going to watch that snap there. So it's very mobile, and you can see why when you cross your legs, when you sit, cross your knees, why that nerve might get pinched on the fibular head and then neck. And then we can just follow that on down the neck. Here's where it gets a little bit tricky. So we rotate the probe clockwise in this case and chase that nerve as it dives to two other branches right there. we're going to stop chasing the nerve there and come back up here proximally to the biceps femoris, and we'll look at that structure. So let's confirm it's biceps femoris, just like we did the LCL a couple weeks ago. And the way to do that, I'm going to roll our patient here, our leg over just a little, and I'm going to palpate that fibular head. So here's the fibula, neck, and then head right there. I'm going to switch hands for the camera to see this position that I'm in. So palpating the fibular head, placing a finger and a thumb on each side of the fibular head. I'm going to plant the probe right between my fingers, and I get the long axis of that fibular head. Now what I'm going to do is windshield wiper, pivot the proximal side of the transducer back and forth. And you can see right there, I'm just going to move the probe instead of the arrow because my hands are full. That's biceps femoris. And look how posterior it is compared to the last webinar when we were scanning the LCL. I had to go slightly more anterior, and we saw the LCL jump over the popliteus groove just under the lateral femoral epicondyle here. So this is the LCL. Just as a quick review of the lateral structures, because we left off here and I said we would go trek into the posterior biceps femoris area on the last webinar. And I mentioned that we would do that on the posterior knee because that biceps femoris is a bit more of a posterior lateral structure. So what I'm going to do now is, here's the proximal LCL, follow it distally, distally, distally. And just as a scanning tip to let you know how I'm scanning, see this round fibular head? My finger is on the back side of it as I'm just sitting here scanning. So I'm resting my finger on the back side of the fibular head, and then I'm just pinching my thumb and my second digit around the neck of the transducer, and that's going to allow me to make that pivot. So I'm going to go here from LCL, and then here you can see the biceps femoris artifact. There's a dark artifact that sits over the LCL, and it can make the LCL look diseased. So you don't want to call that some sort of ligament degeneration right here. What it is the biceps femoris. If I bring my probe up and over while maintaining contact, that's the biceps femoris coming in from the posterior side. And you just don't want to call that some sort of pathology. So vice versa is the same. If the proximal side of the distal side of the transducer is too far anterior, you're going to catch into some of the LCL fibers, and you don't want to call this space and they basically sit like this. You don't want to call that gap between the two some sort of cleft tear or something like that. It's normal. It's a little space between the two structures. It's that dark area right there. And just like we do in anything MSK ultrasound, you're going to want to check the other side if you suspect pathology there. So just to check our work, if I'm scanning here, long axis biceps femoris, my next structure going posterior here should be long axis common perineal nerve. And there it is, right here. And because it's wrapping around that fibular head, I have to kind of pick a direction. Is it going to come in from this way, or is it going to go that way? But if you're right on the level of the fibular head, it makes kind of a V shape how you're going to scan it. So pick a direction. You're either going to go this way, or you're going to go proximal with it. So I'm going to go proximal with it. Biceps femoris, just to check where we are. So here's that tendon of the biceps femoris here, shallow. I'm just going to bring the probe posterior now, and I'll fall right into the nerve. They run nice and parallel to each other, and we saw that when we were scanning it in short axis. If we want to confirm that, you just keep the center of the probe there and just pivot the center of the transducer. Oh, flip the probe the other way. Left side is going to be medial. And I just spun right on the nerve itself. Here's the tendon of the biceps femoris. And if you're not a nerve imager, you're new to scanning nerves, tendons will respond to the anisotropic artifact much more quickly than nerves. Nerves will stay relatively bright compared to tendons, and that's one way to differentiate a nerve from a tendon if they're bordering each other like they often do. The bright structures we're seeing in a nerve are just the epineurium, the little insulated housing. The dark fascicles are the individual nerve fibers, and they're very hypoechoic. So epineurium is mostly fat, and that's why it's not responding so much to the angle artifact like a tendon. Tendon being dense collagen fibers arranged in a parallel fashion, they easily respond to angle artifact over here. So this is biceps femoris again, and then you'll see that the nerve is not responding to that angle artifact very well. We can just keep tracing that back. Here we are. So that about covers all the structures we set out to cover today. I'm gonna open to questions, Laura. If there's anybody that had any questions out there, now's the time. This would be a great place to kind of take a pause. But that is the end of the presentation, in case anybody was wondering.
Yes, we can open it up for questions. There's a Q&A box at the bottom of your screen if you have any questions for Daniel.
There's only so much stuff to look at on the back of the knee on a basic level. You can sit here all day and just talk about nerves. The PCL is pretty cool. Neurovascular structures are just fascinating. Throw the color on, you'd be surprised just how much crazy anatomy is just right there under your transducer. Any blind procedures would just be potentially causing a little hematoma, or a hematomato, one of my friends likes to call them.
That's great. Well, I'm not seeing any questions, but Daniel mentioned that this is part 3 of a series on the ultrasound evaluation of the knee. The other 2 parts can be found on our webinars page, which is on sonosite.com under the education tab. There's also a list of upcoming webinars. There you go. You can see it on the screen right now. Upcoming webinars and recorded past webinars. So feel free to check those out. And we hope to see you at some future webinars. And I want to take a moment to thank Daniel for putting together such an excellent presentation and demonstration. And thank you to our model, Jamie, for loaning us her knee for this hour. Thank you all for joining, and have a wonderful rest of your day. Thanks, Daniel.
Thanks, everybody. Thanks, Laura.